Hi, this is Brian Wormers. I'm recording a lecture today on the care of patients with skin problems for medical surgical nursing at the University of Sioux Falls. Just kind of a disclaimer, there are some images in here that some might find a little interesting. We'll put it that way. So learning objectives, we'll talk about common integumentary disorders. We're going to talk about pressure injuries, including how to grade them, prevention and treatment. And then we'll talk about some parasitic problems. Some of the basics, xerosis or dryness of the skin can be from, contact, so antimicrobials, perfumes, lotions, colors, dyes, different things like that can really irritate the body. Things that we can do over the top of this would be, moisturizing soaps, creams, lotions. Sometimes just even petroleum jelly or a simple Aquaphor or something like that can help out with it. If it starts itching, it's kind of some of the same stuff. Watch out for those antimicrobials and perfumes that some people put on there. And then treatment can be things that decrease that itching. So oatmeal baths with kind of cool water, skin moisturizing, trimming those fingernails and cover with a soccer mitt so they can't scratch. And then some antihistamines, maybe even like a Benadryl or a Zyrtec to help out with some of the itching. Sunburns, very common. I'm guessing everybody in this room has probably had a sunburn. Things that we can do is, of course, aloe vera, cool compresses, trying to keep it nice and tender. Make no mistake, though, if you are seeing some of the stuff, you've got swelling like this is second-degree burns. And so if it's severe enough, we really do need to treat it like a burn, and this might require antibiotics and other treatment modalities that are more severe. So this one, they should maybe even go in and get this seen a little bit, because this has got a potential to get infected. Urticaria or hives, so you're going to see these different kind of a rash, and that can change depending on what type of a rash they have. But the biggest trigger is triggering substances, and so this could be maybe medications that they're on if they're in the hospital, or contact things that they've been exposed to. Or just, really trying to relieve those symptoms. And, cool washcloths can help with this, Benadryls, sometimes lotions, different things like that can help out. Skin trauma, there's lots of different types of skin trauma, but realize that there's different phases of wound healing with this. There's, the initial point where you've got inflammatory response, and then you've got proliferative, where that connective tissue is repairing itself, and then maturation, where it's remodeling and making that new site. So mechanisms of wound healing, first intention, so a wound without tissue loss, so the edges approximated and brought together, like a simple skin laceration. You hold it together and it'll hold up pretty nicely. Second intention, so this is less ideal because the edges are not able to be brought together, and you've got to fill it in from the bottom. So this is like pressure ulcers, and of course this is going to take longer to fill. And then third one, so high risk of infections, and then you got to debride them. So infected surgical sites, or think about some of your diabetic feet or different things like that. Partial thickness wounds, so damage to just kind of the epidermis, or the upper layers of the dermis. Get some reepitheliation, 5 to 10 days, and you're pretty good. Full thickness wounds, like I said, they've got to kind of merge in and then fill from that bottom up. So this is going to take more time. And you need that granulation tissue to fill in, and then contraction develops in the healing process. And the bad thing about contraction is it leaves that scar, and so the scar is not as strong as normal tissue, and it impacts the functionality of it. Pressure injury, so it's when skin and underlying soft tissues are compressed and damaged. Can occur on any body surface, but usually we're talking about bony prominences. So we worry about ulcerations the most, like pressure from the result of gravity, friction from things rubbing or shearing, when the skin is stationary but the tissue below it is sliding and moving. And so this is kind of a good example of these things, because you've got pressure of gravity pulling this body up against the bed. You're having friction between the bed and the skin. You're having shear forces between the skin is staying still, but the body underneath it is moving. And so you've got all these forces acting on the integumentary system, and that causes issues. So I think that this is funny. But make sure you turn your patients. I mean, it's a major thing that we want to be aware of and prevent. So identify your high-risk patients early. You know, put them on a Braden risk scale or whatever risk scale your system uses. Use nutritional assessment, making sure your patients are clean, dry, getting adequate nutrition. Watch their mental health changes. Watch for any incontinence. Diabetes mellitus is detrimental oftentimes for perfusion, and peripheral vascular disease, of course, is detrimental for perfusion as well. So we're going to do aggressive interventions with these and trying to prevent it as much as possible. We can do pressure mapping depending on the different situations. So pressure mapping might be used for somebody's wheelchair if they get ulcerations from that, and trying to look at the pressure that they have while sitting. And so that being said, then we can work on it, fix those. There's different beds, mattresses, overlays, assisted devices, egg crate, gels. I mean, there's lots of different things that we can do with these to try and relieve pressure. Positioning in bed, wheelchairs, wherever else, but just really try and keep them moving, reposition every couple hours, and watch those heels and make sure that those heels are not rubbing on anything. Contributing factors, well, of course, prolonged bed rest, immobility, incontinence, diabetes mellitus, poor nutrition, altered mental status, and vascular disease all contribute to this. Different stages of this. So stage 1, so you got redness, irritation, and you can kind of see it. Stage 2, you've got skin is not intact, no bruising yet. Full thickness, so this is stage 3, bone tendon not exposed, but might have undermining and tunneling. So that's, you find, use like a cotton swab or something like that and see if there's any tunnels that develop with this one. Stage 4, full thickness, and you've got tendon, muscle, or bone that you can see, unfortunately. Usually have undermining, tunneling, and you got some slough and eschar, so dead tissue. Also be aware that there are unstageable pressure ulcers, and with that it is the depth is unknown because of you've got some sloughing or eschar that obscures it, and so you can't really quite tell about if it's full thickness or where it's at. So it's all right to say unstageable, and that's a commonly used term. Additionally, things that we want to do and assess, so look, where's the location at? Look for bony prominences, of course, the size, the color, the extent of tissue, any drainage, condition of surrounding tissue, presence of any foreign bodies. All those things will impact how we care for these wounds. Now, an exposed wound is always contaminated, and so you're going to hear this from wound ostomy care, that unless you're in the operating room, everything is contaminated. But realize that not everything is infected, and when it gets infected, that's when things get bad, and that's when we need treatment and intervention at that point in stage. But realize that we're all contaminated. We've all got bacteria on our skin, and that most of the time that's fine, and usually it's beneficial. So interventions we can do with this. So we can get physical therapy on board. They can do whirlpool treatments, dressing changes, different things like that. Talk about different positioning and sitting and using of assistive devices. Drug therapy, so if it's infected, of course, we can talk about antimicrobials. Otherwise, different things that help with that skin. Nutritional therapy, of course, they need adequate calories, protein, vitamins, minerals, and water. Lots of new technologies are coming out. Wound vacs, which you've seen, hyperbaric oxygen, which these are not new. And then topical growth factors, skin substitutes, and maybe even like an e-stim. Surgical treatment, you can do debriding, grafting. There are lots of different types of surgical flaps that you can do with this one. Moving on to more bacterial infections, so folliculitis. So this is like of an infected hair, and so on this patient, looks where he was shaving, he got it pretty bad. Often it's from shaving or hot tubs. So that being said, this looks like a great big cesspool to me. Although in my younger years that probably would have been fun. But just realize there's probably a lot of bacteria in this little hot tub. Furnicular boils, so a much deeper infection in the follicle. So just a little bit bigger, redder, and then you can get cellulitis. So cellulitis is usually either staph or strep, and it's going into the deeper skin tissues. So with this, we kind of want to watch the outside. On her face, I would not probably take a Sharpie and do the outline of this to track it. But on some of the other surface areas, we might with a skin marker. Not necessarily a Sharpie, but a skin marker. Herpes zoster or shingles. So this occurs after a patient's had chickenpox or been exposed to that virus or has that virus in it, and it something triggers the body to erupt, and it kind of goes along these dermatome paths. Tends to cause a lot of pain, especially neuralgic pain, and so that hurts significantly. And so patients will often complain of a lot of discomfort, and like I said before, this rash and kind of a dermatome type of layout. Last couple of different weeks, we can give antivirals for this, but oftentimes just kind of supporting them through it, and it'll resolve on its own. Viral infections like herpes simplex, and so this is kind of a severe case of this, or around the mouth. So you can kind of see these type of things, and of course that's going to be treating with antivirals. Fungal infections, so of like the fingertips or of the mouth, we can get. So with these fungal infections, of course, we can do different treatments. There's topical meds that we can put on this. There's systemic meds that we can put patients on. Tinea capitis, so this is a fungal of the scalp. So cap, think head, the cap goes on your head. And tinea is fungal. You can get tinea corporis. And this tinea is commonly called ringworm. And you kind of see the annular or the ring-like pattern here. Other fungal infections, so Candida albicans in your mouth, they'll call it thrush. So lots of fungal different things. So when we got these infections of the skin, of course, we want to focus in on proper cleansing of the skin. Isolation precautions so it doesn't get spread to other people. We might follow up with some culture and sensitivity if we're trying to figure out what it is, CBC and biopsy. Drug therapies, depending on what it is what we treat it with. So if it's bacterial, and then antibacterial. If it's fungal, antifungals. Sometimes we'll use anti-inflammatories just to try and calm the body down. And then if it's causing pain, of course we use pain management, including some drug therapy and some other modalities as well. Parasitic disorder, so lice, so pediculus capitis, so capitis means on top of your head, remember. Scabies, so this little creature burrows in and causes complications that way. So it's a nice way that you can kind of see it. Them burying in doesn't really hurt. What hurts is when they have their excrement in these tunnels, and then that causes irritation. An interesting way to do it would be like use like a Crayola marker and run it across the skin and see if it's pulling it into any of the tunnels if you're concerned about scabies. Bed bugs, so outbreaks everywhere, I think. Hotels are it's common for hotels to have bed bugs, but they cause little bites across the body. Usually it's on the exposed area, so this looks like to me side and back. So maybe was sleeping without shirt on or something. But usually it's where there's open exposed skin. Other common inflammations, so eczema. Eczema is a very common type of situation in which you can kind of see this dry, patchy, scaly skin. Contact dermatitis, often from metal is where I've seen it a lot, or being involved with something that's touching it, or lotions or creams or makeup. I've also seen it from like the nickel of blue jeans. So if you get a button, I've seen that nickel cause some problems that way too. Chronic atopic dermatitis. So once again, you're seeing this redness, skin breakdown. Either the fact that if they're scratching and itching a lot, you're getting these open sores. Psoriasis. So a couple different types. I mean, plaque psoriasis is one of these. Or psoriasis vulgaris. You're seeing it more spread out throughout the body. Treatment's a little interesting for psoriasis. Some of the things that NCLEX loves to talk about would be tar preparations, which is kind of interesting, and then UV light therapy. So we usually try and tell people to stay out of the UV light to prevent skin cancer, but for psoriasis, this is an effective therapy. Other things we try to do is calm the body down with either immunomodulators or corticosteroids. We can use other topical therapies, like different creams and stuff like that. And then, of course, emotional support with any of these integumentary stuff, because people tend to see your skin. So we can talk about skin tumors. These are benign ones. This is more of like a keloid. So sometimes that forms more so on African Americans than on Caucasians, which is kind of interesting on this one. And usually the keloids will form after surgical incisions. But these are benign tumors. Sebaceous cysts, so you're seeing these fluid sacs forming. Pilonidal cysts, so this is at the top of the butt crack, and so probably not the appropriate word for it, but everybody knows where I'm talking at. And so right here, and it's often inside these pilonidal cysts. You can drain it and once and see if it works, but if that doesn't work, then often what there is sometimes there's some hair or some bone fragments or something in there that's causing irritation and swelling, and that has to be surgically removed at that point in time. So some people will say that's remnants of, of a tail in humans from years ago, but just realize that this might be something that needs more of a surgical correction than just a simple IND on it. Other skin cancers, so squamous cell carcinoma, basal cell, and melanoma. Melanomas are usually pretty dark. So treatment of skin cancer is often surgical. So might be freezing it with cryosurgery, electrodissection, excision, so cutting it out, progressive cutting, so it's scraping off layers until you feel like you've got it all and you can send that to path, or doing a wide excision and trying to cut around all the tissue around it. Non-drug surgical type of situations, I suppose we could use radiation therapy or other medications, but usually what I've seen for skin cancer is it's often a surgical manifestation. Stevens-Johnson syndrome, so I know that you guys have talked about this and TENS in pharmacology. I just wanted to show you what slides are. And so skin gets red, irritated, and sloughing. And so think about this person laying in bed, and we talked about all the different friction and shearing forces and stuff like that. Now imagine if the skin is brittle to begin with, and what that would do to his skin. Stevens-Johnson's and TENS syndrome, we really treat it like a burn patient, and so we want to be very careful. We want to keep that as clean as possible, and that they might go on different antibiotics, which is kind of sad because antibiotics are often some of the main causes for Stevens-Johnson syndrome and TENS. So, and this is your TENS. So they look very similar, and they're both not great for your patients. So, that being said, if you have any questions, feel free to contact me, as this concludes our presentation on the integumentary system.